Hello, I'm Dr. Ahmed, a research fellow in the section of surgical oncology at Stanford University, representing our group. We evaluated predictors of response to neoadjuvant chemotherapy, including imaging, biochemical response, and pathologic response upon resection for pancreatic cancer. This collaboration has study members from Stanford section of surgical oncology, Department of Pathology, Department of Medicine and Medical Oncology, and the School of Medicine. Neoadjuvant chemotherapy has been a beacon of hopeful improvement in outcomes for patients undergoing resection for pancreatic cancer. However, the optimal measurement of response to treatment has been elusive. Response to treatment can be evaluated by a change in tumor size radiologically, biochemical response with CA19-9, and through pathologic analysis post-resection using a score called the tumor regression grade. We evaluated the predictive ability of these biomarkers on survival. We developed a retrospective database of patients receiving surgical resection at Stanford from 2011 to 2021 for pancreatic ductal adenocarcinoma with preoperative neoadjuvant chemotherapy. Radiographic CA19-9 and pathologic response were analyzed with respect to overall survival using Kaplan-Meier method. Biomarkers and outcomes were compared using log rank and Cox proportional hazard methods. Overall, 146 patients met criteria and received neoadjuvant chemotherapy. The majority of patients received FOLFIRINOX, which constituted 101 of 146 patients. 21% of patients also received radiation, and 51% of patients required portal mesenteric venous reconstruction. Overall median survival was 53 months. Figure 1 denotes survival analysis with individual and combined biomarkers. In Figure 1A, CA19-9 decrease of 25% or more was significantly associated with improved overall median survival, with median survival not reached versus 23 months based on patient group allocation. In Figure 1B, a tumor regression grade score of less than or equal to 2 was associated significantly with improved overall survival, with 53 versus 28 months, depending on group allocation. In Figure 1C, a decrease in radiographic tumor size of 50% or more was significantly associated with improved survival, with median survival not reached versus 35 months, depending on group allocation. Not pictured is an analysis of RECIST 1.1 criteria. RECIST 1.1 criteria is a standardized evaluation of radiologic tumor size to assess response to treatment. This was not significant or predictive of overall survival in our analysis. Furthermore, on multivariate analysis, we found that only biochemical response of CA19-9 decrease of 25% or more was significantly associated with overall survival, with a hazard ratio of 0.36, while the other biomarkers were not. In conclusion, patients with radiographic, biochemical, and pathologic response to neoadjuvant chemotherapy have improved prognosis. Biochemical response of CA19-9 appears to have the best predictive capability for long-term survival. This study was limited by treatment regimen and should be replicated in a larger cohort with multiple institutions to understand if our predictive relationships hold with different regimens, including chemotherapy and/or radiation. In the future, response to treatment using biomarkers may assist in guiding the optimal choice of neoadjuvant chemotherapy prior to surgical resection, offering hope for improvement in care for pancreatic ductal adenocarcinoma.